Yeah, hi. Anup, we are live.
Yeah.
Good evening, gentlemen.
Okay. Perfect. So good. So well, in all, I'm Dr. Anup Dhamangaonkar. I'm the organizing secretary for 2024. So as a prelude, we have set up a series on different subspecialties. Case, what are the potentials that our delegates can take home? What are the topics that we are going to discuss during the conference? And this is going to be just an advertorial for the main conference. So please be sure to be there. The topics for WIROC 2024 are highly curated to suffice your requirement in day-to-day practice. The topics that we're going to cover are going to be the controversies, the debates that we face during our day-to-day practice. We'll have the who's who of the orthopedic fraternity to discuss bear these particular controversies. And I'm sure if you attend this conference, it will change your practice. So please be fast. Registrations are filling fast. Be sure, be there. Please register for the conference. And with this in mind, I think we'll start off with the webinar for the day. The webinar that I've thought of is my transition to robotic TKR. Now, this webinar is basically designed for surgeons who are sitting on the fence, who are yet to decide whether they really want to go in for a robotic TKR or are they happy with their conventional. I think each of us has been through the same. We all have undergone this transition, and that's what we're going to discuss. So, what are the thoughts that come into our mind? Whether I really need one? Which one do I choose? What is the chance of getting my surgeries wrong? What if the robot breaks down? Is it my kind of high volume TKR? And for this particular for today, let me welcome Dr. Mahesh Kulkarni, sir. He's from Pune, Dinanath Mangeshkar Hospital. Dr. Vaibhav Bagaria from HN Reliance Mumbai. Dr. Adarsh, he's the MECO proctor as well from Hyderabad. Dr. Pramod Bhur from New Bombay. Dr. Raja Bhaskara from Coimbatore Ganga Hospital, and Dr. Shiv Kumar Satpure. He's from Sambhajinagar. So we have got faculty who have been through this phase. They have passed it, and therefore they are authority to speak on the same from various dialects, various geographical and demographical locations in Mumbai and in India. Okay, so with that, let me start off with the first talk. I think I'll just share my screen. Am I, is my screen visible?
Yes.
Yes, please start the slideshow.
Yes, sure. So the first step in adaptive care is getting convinced. So we have all got through this phase, and we all know that TKR is proven an effective and a cost-effective procedure with a high survivorship of over 90% at 10 years. Still, there are those 20% patients who are dissatisfied. Reasons are many. Reasons are plenty many. So we have all known that the X-ray looks pretty good, but the patient feels a little bad. So the time to recovery is a little less in a few patients. Some patients really spring up into action quite soon. So why is this so? So we are putting in an artificial joint in an arthritic knee and hoping that to be as natural as pre-arthritic. There is a CPAC classification that we are all aware of, which shows that there is different morphometry of knees, which is their natural knee feeling. And we are trying to get our HKAs balanced in all patients in the same direction through conventional surgeries. And we hope that this can replicate the normal knee. And that is something that is a task that is difficult for us to find or match. So here is something that I would want to show you. This is on the left is what we into an HKA00, and we release the tissues on the inner side, on the medial side or the lateral side. And this is what leads to some kind of disability post-operatively, the releases that we do, some pain. What we would want to do is not release anything and still achieve the HKA. And what we are trying to do now, we are trying to get our implants oriented in a way that we can balance the HKA without releasing a lot of soft tissue, even in some of our deformed knees. When we think of what is the need to do something different, we follow the inversion principle, where we turn the question upside down, current practice. So I'm sure we'll relate to whatever we are seeing now. While we are doing a conventional TKR, there's no native tension data that is registered. There's a lot of soft tissue handling, tibial subluxation that we do. There's a jig-based system that we use to not be exactly 9 mm. We may cut less, some more, and that is dependent on the experience of the surgeon. Most surgeons attempt to cut at 90 at the tibia. It may not be 90. It is not validated. The tibial slope may not be native. We keep a valgus angle of 5 degrees in most of our cases, external rotation at 3 degrees for most of our cases. And once we fix in our implants, we do the rest with the balancing of our following the releases. So after doing so many things, which are common in so many different knees of different patients, and then we expect that the knee should be a forgotten natural knee. And that is something that we need to keep in mind. Let's say if we have a varus cut, it's a non-calibrated correction that we do. We don't know how much we're going to correct. The curve fair is not measured. There's no real-time balancing data available, and it leads to non-quantified releases in most cases. And therefore, we rely on the experience of the surgeon again. Now, from the patient's perspective, we want every knee to be as good as the 100th one. What we're trying to do now, through our conventional technique, we are trying to impose the same technique on different patients. It's like distributing the same kind of shoe size to all the athletes, same shirt size without the nitty-gritties of fitting to all our patients or subjects. Also, what we have seen in the early post-operative period is the pain perception of patients is significantly less. The balance is significantly high because the soft tissues are released less. So understand this patient, the student on the left, he's forced to study. The student on the right is enjoying her studies. They both scored the same marks. But what do you think is the memory of experience of studies? I think this is what is absolutely important. The memory of experience of the procedure is very important for the patient to basically undergo the next knee, or it brings bad repute to the procedure itself. So what would we prefer? We prefer to do something that is in post-operatively, at least in the early post-operative period. This situation when the patient is saying that, doctor, my knee is still pain, that your knee is perfect, x-rays are perfect, and that's the kinematic conflict or the patient-based conflict that we are going to face every day. So therefore, success of any surgery is not only knowledge, it is not only execution, it's validated execution, and that's where robotics come into the picture. When we talk of technology, all the technologies that we are going to use and also have used in the past have undergone this cycle. The first phase of any new technology is denial. I'm not going to use this technology. The second phase is competitive need. When my peers are using it, I should be the one who is using it. The third is irreplaceable acceptance. When you think that the technology that we are using is quite good, it is going to give us better results than the current outcome, and therefore it substitutes most of the technologies. For example, computers, internets, cars, mobiles, banking, we name it, and the technology cycle is followed. Is the cost too high? We've seen that with mobiles, pagers, and now we see that mobiles being used with vegetable vendors as well. So volume discounting will definitely get the cost down. What stays in market is what benefits. Even if it leads to early post-operative pain, which is less, it is still worth it. If it can reproduce the same balance in each of my knees from the first till the 100th, it is still worth it. If it gets me ready for augmented reality and robotics in the future with n number of possibilities, it is still worth it. Hence, I have transitioned from the conventional to the robotic surgeries, and I think that's the way to go. We'll hear on from experts what is the future take, and I'll leave it at that. I thank you for your patient hearing. So now we have different robots which are available. I now request Dr. Pramod Bhor to share his screen and set on display what is on platform of robotics TKR. All over to you, Dr. Pramod Bhor.
Yeah, so basically, thanks, Dr. Anup, for inviting me for this talk. You are able to see my screen, I believe. Are you able to see my screen, Dr. Anup?
Yes, sir. We are able to see your screen.
So, today's topic, which you have to wish to choose, so robotics have come to a phase, as you said, the first stage of denial we have crossed, and we've come to a stage where there is a stage of acceptance. So coming down to that, we have conventionally replacement computer assisted and robotics. So if I compare it to our car driving or a parking of a car, so manual parking is what we say a conventional TKR looks like. The second one, which we see, is what we have nowadays, where we are seeing on our screen. And the third is third kind of parking is auto park, where the car parks itself. This is what is robotics. So coming down to that, now there are many robots that are available. So we have done computer navigation. Navigation has helped us over a period. Navigation helped us in placement of the femoral and the tibial zigs. But the bone cuts were taken by the surgeon, and only after the cuts were taken could we validate the cuts and change them later. So that was the thing that was happening with navigation. That is why we have come to the stage of robotics, which is basically a controlled cuts at the time of the surgery. So if I go with robotics, there was quite a good amount of questions raised earlier whether we should go ahead with robotics or we should not. So there is a good amount of data that is available now, which says yes, robotics is helping specifically in UKRs as well as the TKRs, and with time, definitely it is here to stay. So because of that, there is quite a few companies or quite a few implant brands have launched their robots, and there is quite a robotic war going around, which robot is better and how to go ahead and how to choose the robot that we are supposed to use. So when I got the robot, the same thing had gone into my mind: how to go ahead, which one is better, what is better. Yes, so there are quite a few robots that are available in India. So let us go ahead. So if we go ahead and see the old generation robots, which is Robodoc or Casper, they did not have they were CT-based robots which were there, and they did not have the haptic boundaries. But nowadays, what we have are haptic robots, which are more which have evolved, and they are now more safe and ready to use robots. And these are third generation or fourth generation robots. So what we have in our country right now is QS and Mako, which are CT-based robots. Then Kuri, which is a non-CT imageless robot. Belis, which is an imageless robot. And Rosa, which is also an imageless robot. So these are 5 robots that are available for us in our country at the moment. So if I go ahead and classify them, so how do I decide which to go ahead? So there are 5 robots. I cannot be using all the 5. So if I go ahead and classify them into two, this thing, image-based and imageless. So now image-based is a robot which uses a CT. So in those cases, we are using a CT for prior planning before the surgery. And imageless is directly at the time of surgery. We are going ahead and doing the surgery at the time, directly planning on table, directly seeing with the help of the sensors on the board. So in image based, it is 3D dependent, CD dependent. We take the CD, we take the 3 CT, The images are loaded on our laptops. We make a plan accordingly and get the post-operative alignment pre-operatively only as which is the targeted. We see to it that we get the optimal size and alignment. So if I'm going ahead and if I we are doing, so there are quite a few people saying that if you are planning properly, the sizes are definitely specifically in the femur they are 100% matching as compared to the other as compared to the tibia also. Leg length and offset restoration can be done. Only a disadvantage of using an image-based robo is the cost of the CT, which is an increased cost to the patient as well as the radiation that is the patient is exposed to. I think which is quite a few minimal. So this is what we see in a CD. So we get whole planning. The planning is done prior to the surgery, 1 day prior, and this planning can be transferred into the robot at the time of surgery. Similarly, in case of imageless robots, what happens is that we are relying on the patient anatomy. At the time of the surgery, the landmarks that the bone, these are marked by the surgeon, which normally can sometimes cause some amount of human error at the time of surgery. But that you can mark the femur as well as the tibia or the bony points accordingly, and then plan at the time of surgery. And the surgery is faster in using an imageless robot. Pros is no need of CT. It is easier to do an imageless robotic system. So if I consider the robots that are available, imageless is Cori, then that is Smith and Nephew. Then we have Willis, which is Johnson and Johnson Depew, as well as then we have Zimmer, that is Rosa. These three are imageless systems, and Cubis and Mako are image-based systems, which are there available in. So now coming down to the second way which I classify these things is upon the resection methods, how the bone is getting cut. So we milling with irrigation is used by Cubis. So it is an automatic system. It has a miller, and along with that there is an irrigation. So there is the miller is irrigation is used by Cubis. Saw with sensors is the commonest used. It is used with Mako, Willis. These are the birds are used by Smith and Nephew, and the Rosa system, that is Zimmer system, has got it does not have any cutting system. It just places the zig, and the cutting is done by a conventional saw that the surgeon has. So as I said, Mako has got a saw system with sensors. The sensors are available at the time of cutting. It is completely monitored. Cubis has got a miller system along with irrigation. Willis has got a saw-based system with sensors. Navio or Cori has got a burr system, which causes a little bit amount of friction at the time of surgery. And we have Rosa, which normally places the zig. In case of Rosa, there is only zig placement. So depending upon these, we normally I can classify the robots into three categories: passive robotic systems, which are either based on the computer and navigation. They do not have an haptic feedback in that. So Rosa is one of those passive robotic system. It just applies the zig to the bone, and the cuts are taken by the surgeon. Semi-active system, we have Mako, we have Willis, as well as Cori. So in those, the robotic arm does not perform the bony preparation. It is held by the surgeon. The saw or the burr is held by the surgeon. It is within the confines of the haptic constraint predetermined by the surgical planning. An active system is basically an automatic system which is done by Cubis. The robotic arm itself performs the cutting. The surgeon maintains the control via the emergency or the manual override. So if I consider all these different this thing, so Curexo has got Cubis. These are all closed systems. Curexo has Merrill implants. Mako has Stryker Smith and Nephew implants. Rosa is for Zimmer implants. Nevio or Cori is basically for Smith and Nephew implants, and Wellis is for Depew implants. These are all closed systems. First two, that is QVIS and Mako, are CT-based systems. These are image-based. Rosa and Navi or Wellis are non-image-based systems. In Rosa, there is a software where X-rays can be used as image-based using X-rays. They have a software for that. Depending upon the cutting system, QVIS has got a fully automatic Miller system. Mako has got a it's got a saw based with sensors. Rosa is a passive system, does not have a cutting system. Navio has got a bar, and Wellis is a saw-based system, table-mounted. And it's a very small, sleek system that Wellis has. So when we come to the OT settings, it is basically the robot comes from behind you. There is a sense the OTS is in front of you where the sensors are available, are seen. Exposure is basically similar medial, parapatellar, or subvastus, depending upon surgeon to surgeon. So if I consider a QV system, this is how the points are marked. So we are marking the points in this manner, in this way, and that is the reason why we have to. There are around 40 points. So in systems like Wellis and everything, Wellis as well as Cori, the marking is done by painting on the bone. Whereas in Mako as well as in QVIS, we have to mark the points. Painting is faster as compared to marking the points with this. As I said, I'm using the QVIS system. This is how the automatic Miller works, making the cut inside the haptic boundary, keeping the edges free, and quite a safe procedure. The femoral cuts. These are some of the pre-operative and post-operative pictures. This is what we all want. We want all our patients to be walking and dancing post-surgery. This is how it changes the thing. It's the patients walk faster as compared to this thing. So considering all this, I would suggest what is an ideal robot? I would prefer an open system instead of a closed system. Right now, we have all the robots which are basically having either this implant or that implant. So if it is an open system, an ideal robot is one with an open system. It should have different cutting options, either Miller or saw-based. It should be automated. I feel imageless is better than imageless. Basically, I have not used imageless too much. But frankly speaking, if I am going for something which is more precise and everything, I would like to plan a little bit more. Yes, definitely I would. And one more thing that I would like to add upon is to have a pinless sensors, so that you do not have to put pins in the tibia and the femur, where not causing stress like this. So ideal robot is one which is open system with different cutting options and the pinless sensors. Thank you. Thank you for the patient hearing.
Good. Thank you, Dr. Bur, for a wonderful talk. So now we have got convinced that we need to do a robotic TKR. We have bought a robot after seeing what's on our platter. Now, do you think our first few cases will be very easy, convenient? What will be the roadblocks? Will there be any speed breakers? And we'll have Dr. Adarsh to speak on that, his experience of his earlier cases. And it's all over to him. Dr. Adarsh, welcome.
Thank you, Dr. Anup. Dr. Pramod, can you just stop sharing the screen, please? Dr. Pramod? Yeah, thank you, sir. Very good evening to everyone. Wonderful talk by Dr. Pramod sir and Dr. Anup. I would like to thank Dr. Anup for inviting me here today, and it's a pleasure. It's an honor to be speaking for WIROC. I'm sharing my presentation. Please let me know if you can see it now.
Can you click again?
Are you able to see it?
Yeah, now it's seen. Yeah.
Perfect. Okay. So I've been given the topic. The overarching theme of today's webinar was my transition to robotic surgery. And as very beautifully explained by Dr. Pramod and Dr. Anup already, I think the decision has been made, I mean, in our journey of today's webinar, that robotic surgery is good. But the pertinent question is it a cakewalk? Were my first few cases a cakewalk or not? So that's what I want to discuss with you. So the question, is it really a cakewalk? Is it just going to come and then suddenly be like, hey, the robotic surgery is God's gift to mankind? Let's see how it goes. So we'll give our own journey with robotics to give you this idea. So our journey to robotic excellence was a long one. I don't think we have even reached there yet. We have still a long way to go. I think there's still a lot of untapped resources that we think we have to go after. But if you just take our journey with robotics in a nutshell, we started Sunshine Ortho Robotics in February 2020, and we acquired our first Mako robot in Feb 2020. We did a good number of cases, and then in July 2021, a year and a half later, we got our second Mako because we had such a huge load of robotic cases. And May 2023, we expanded our horizons and we got our first QVIS robot. And then May 2024, that is a few months ago, we got our first Velis robot as well. So now we have experience of 3 different types of robotic systems. One is a semi-automated image-based Mako. We have a fully automated image-based QVIS, and we have an imageless robotic arm Velis. So I think what I'm going to do is I'm going to divide my first few cases in each robo and see the different kind of challenges that we faced in the beginning of each robotic journey. In a nutshell, presently we have done more than 5,800 total robotic surgeries amongst the 4 robots stationed at 2 centers. That is including total knees, partial knees, and total hips as well. And our average procedure time has now come down to 45 to 60 minutes because we have multiple surgeons. We have a little bit of varying times, but on an average, 45 to 60 minutes is our surgical time. And trust me, it took a while to get there. It was not a walk in the park. So let's see the challenges that we have in the chronological order. First, we started with the Mako. When we got our first Mako, and during our launch, these are the challenges that we faced. The first was the feel. So I'm going to divide these challenges into different categories. So first challenge that we had was the feel of the robo. There's a different feel of the saw as compared to a manual saw. That's the first thing most of the robotic users, especially Mako users, will realize. It's really not the same as doing a conventional saw. When you go in for your cadaver lab or when you go in for your first case or your sawbone, you try to take the saw and try to do it the way you do with a conventional case. It will never work, and your system will keep on jamming. And that's one thing that you have to do. Second thing, it's now connected to a robotic arm. It's not completely under your control anymore. That saw, which you earlier were completely, wielding as your weapon, is now partially going to be corrected or going to be policed by the robot. So here, like earlier, we used to do side-to-side movements with the saw, but now once you give the robot, especially the Mako, it's back and forth movements which has to be done rather than a side-to-side movement. So this is something that we really had to get used to. Another important thing is not to put increased pressure on the saw. Earlier, if you have very sclerotic bones, you're going to, like with the conventional saw, you push a little harder, you put a little more force, and then you can cut that bone. If you try doing that with the Mako, it's going to shut off the power. So instead of doing that, you have to keep rocking back and forth. And this is something that you had to get used to initial days. So I'll just give you a small glimpse of how we do it. If you see, I'm going for a back and forth motion. You notice that instead of going by side, I was doing a back and forth motion. I'll just show you again. See my saw hand going back and forth to get out the bone that's required to be gotten out. Next issue that we had with our robotic cases was the trust. Obviously, you're not going to trust a machine as soon as it comes into your orbit. It took a while to completely trust the accuracy of the machine. In the TKR, I'm going to talk about TKR as well as THR. TKR, we have to trust the robot for the haptic boundaries. It's telling us that it's not going to allow you to come out of the haptic boundaries. Don't worry about the soft tissues. But in the initial days, you're not going to trust it blindly. You're going to be a little bit skeptical about that. Secondly, you're going to be a little bit wary of the accuracy of the angle of cuts. You're saying you're putting 2 to 3 degrees of varus. Is it really going to be 2 to 3 degrees of varus, or will it end up being more, like a 5 to 6 degrees of varus? So initial days, we were very wary. And as we went along, we started to trust it more. And most importantly, over time, we learned to look at the screen rather than the field. This is one of the biggest changes that we made from our conventional surgery to our Mako robotic surgery. Obviously, when you're doing a conventional surgery, you're going to be looking like a hawk right down at your bone, right down at your field of surgery and your ligaments and everything. Once you start trusting that the accuracy of the robo is top notch, the haptic boundaries are not going to allow you to damage your soft tissues. Now we always look at the screen when we're doing our cuts. Just look at how I look. I'll be looking at the screen. My eyes are looking at the screen while my cuts are happening over here. And you can see what exactly I'm looking at. I'll show you. Because I have this information that this is the amount of bone that needs to be removed. These are the haptic boundaries. I know that I'm not going to be damaging my soft tissues. What about trust in total hip replacement? The total hip, we initially were wary about the angles of the cup placement. Is it really going to match 20/40? Initially, we used to think that when the cup is showing maybe 20 degrees, it looked retroverted as what we would normally think. So normally, then we realized over time that what we were putting in our conventional cases were probably too much anti-version. Because then we started trusting the robo that 20 degrees is probably less than what we were putting in conventional cases. Secondly, a single ream. Earlier, we were doing serial reaming until we got the rice grating sensation. But now once we trust the robo, we know that we can go for a one size down reamer to what we planned and just go in every single time. And most importantly, after the first 20 cases, we trusted the robo well enough to not have any more trials, do the ream and do a final impaction. I'll just show you how this works. I hope you can see the video.
Yeah,
So
we can.
So once you've done the registration, the reamer goes in. Just go directly to the one size down reamer that we had planned and just keep reaming until the green part goes away. Again, I'm looking at the screen, not looking in the field. And I just make sure that the green goes away and all those numbers which I'm showing you turn to 0. As you can see over here, the green goes away and all my numbers turn to 0. Secondly, the impaction of the cup as well. Here, the robotic arm locks in to what we have planned. If you can see, the plan was 40/20 and it locks in to 40/20. And as I said, after the initial few cases, we started to trust that this is 100% correct every single time. And we bang it in. And if you can see the distance remaining, it shows 8 proud. As you bang it, we keep recording. Now we're 2 proud. And now we're 1 proud. So this is also something that we learn to trust over time. Next, time. This is the most important thing, right? Because everybody in the initial days used to dissuade us saying that you have so many cases, how are you going to fit in the list if you're going to spend 2 hours for each knee? Yes, initial cases almost took double the time. Double the time. Imagine doing like around 10 cases a day and then having to double the time. It's like used to be really cumbersome in initial days. Slowly we became time neutral. And then as we started trusting the robo and getting more well-versed with it, we actually became faster when we were doing robotic surgery. We even published this paper just this year, operating room efficiency for a high volume surgeon in simultaneous bilateral robot-assisted total knee arthroplasty. Basically, we studied cases which were done simultaneous bilateral, conventional, first 50 Makos and the next 50 Makos. So if you see this table over here, what we found was, this is bilateral, mind you. So the frequency distribution of the operated time in conventional TKRs, which was the blues, first 50 RATCAs is robot assisted is the reds, and the last 50 RATCAs is the green. If you noticed, 60 to 90 minutes for a bilateral case, we had a higher percentage of the last 50 RATCAs, and the first 50 RATCAs were very high. That is more than 180 minutes. And the conventional is somewhere in between, around 90 to 120, the maximum number. And you can see this table as well. If you compare the first 50 RATCAs to the conventional cases, the first 50 RATCAs, the mean operating time was almost 2 hours, and the conventionals are obviously less, 115. But then when you came to the first 50 versus the last 50, our time drastically reduced from 127 to 91, right? So that's a huge reduction in the time from the first 50 to the next 50 RATCAs. And this is the graph that we plotted of the last 50 RATCAs to the conventional cases. Initially, obviously, we were taking longer, but as we went ahead, our robotic bilaterals were even faster than our conventional bilaterals. And if you take the cumulative minutes, we actually calculated cumulative minutes in all the 3 types. The first 50s obviously took the maximum amount of time. if you take cumulative minutes. Conventional take the second most amount of time. And if you see the Lex 50 robotic knees took the least amount of time for bilateral cases. So as you can see, took a while to get there, but as we went ahead, we actually became faster than we were doing earlier. Now, the most important challenge that we faced was philosophy. The biggest challenge in our practice, the biggest challenge was our philosophy. We had to unlearn what we were doing, as Anup sir was mentioning about mechanical alignment. We had to completely unlearn what we were doing in conventional cases and learn a completely new philosophy. We had to embrace something known as functional alignment. Intentionally putting implants in varus and valgus, which was sacrilege earlier. In fact, our boss, Dr. Guruvareddy, published his book, and he has his most famous video, The 10 Commandments, where we are always taught to put it in 90 degrees or completely perpendicular, which was in the earlier days. We still follow it for our conventional cases. We had to start to unlearn that and start putting our implants in varus and valgus. So on the left, you have the conventional, the mechanical alignment. We take a perpendicular to the mechanical axis of the femur and the tibia. And now we can play around with the implants, 6 degrees of movement in the 3 different planes, and that is called functional alignment. Basically, we were converting our religion. We were the same person who used to be doing one particular, following one religion. Suddenly we had to switch to completely 180 degrees. And this was something that it took us a while to get used to. So just a quick glance of a functional alignment technique, which has already been mentioned earlier. So if you have a graph like this, 22 mm, 20 mm gaps in extension, and 23 mm and 18 mm gaps in flexion and lateral and medial side, just by playing around with our implants, get the tibia up by 1 millimeter, get the femur down by 1 millimeter, put the tibia in 2 degrees of varus, external rotate the femur by 4 degrees, and then put the femur in valgus of 1 degree. By just tinkering around with these implants on the virtual screen, I'm just going to skip through because this is not about functional alignment. You can see at the end of the day, I'm going to end up with 18, 18, 18 gaps. If you can see here, this is a perfectly balanced gap just by making minute adjustments. And this is the gist of functional alignment. And we realize if we are spending so much money on a robot, we have to adopt different alignment strategies and embrace non-mechanical aligned knees. Otherwise, we're just getting a very expensive cutting tool. So then pushing the limits. So till now, in the initial cases, we're only doing straightforward ones by robotics. But then the question that was asked was, what's the need in those cases? You're getting great results in straightforward needs anyway. Why are you bothered to get a robot in for these straightforward cases? And back then, there was no literature because all the literature was from the West, where they don't have such complex cases as we do. Then we started pushing the envelope in terms of complex cases where technology would be of much higher value. And we started putting our own ideas into our complex needs. And we started using the robo for the complex needs. And we published our paper, Enhanced Mid-Resection Workflow Technique for Severe Varus Deformity Correction using Robotic Arm-Assisted Total Knee Arthroplasty. This is our algorithm. I'm not going to go into the depth of this, but the point is, after the initial few hundreds of just doing regular straightforward TKRs with the robo, we realized that we can actually expand our horizons and use the robo for even more important things like the complex deformities. And the next step would be to adopt to revision cases. Right, now let's go to the next part of our challenges, which is when we got the QVIS, okay? So the challenges with the QVIS initially again was the time. Finally, we became fast with the Mako, but a new system added again to time, and it took more than 2 hours per joint initially. Even after getting used to the new robo, it still takes 15 to 20 minutes more than the Mako because it has auto burring and we can't speed that auto burring part up. So it's slightly longer than a Mako case. And if you can see here, this is how it's done. The auto burr is again, it was already shown by Dr. Pramod. And in this step, there's really nothing we can do to speed it up. We can in a Mako, just it depends on the surgeon's speed, but here you have to wait till it completely sculpts out the bone. Then safety. This is something that we were really worried about initially. Wary of the risk of vascular injury near the posterior aspect of tibia during burring. Now, when we have the Mako, we have the haptic boundary, and also you are still controlling the saw. When I'm going towards the back of the tibia, I can just be a little wary and go a little slow. But when I'm doing the QVIS, it is burring out. So we were very, very nervous about this in the initial days. But over time, we got confidence in the safety of the boundaries. So till now, touch wood, we have never had any mishaps. And I think it's safe to say that the QVIS is also a very, very safe robot. The most important challenge we faced with the QVIS is ego. It's one big thing that every surgeon faces. What do I mean? It took a while to relinquish the knife to the robot. right? So everybody was talking about robots replacing us in the workplace. And then when we did the Mako, at least it was still assisting us. Okay, but when the QS came, it was like, boss, let me do the cutting for you. And we're sitting on the side, and then suddenly we feel a little bit kind of what you call redundant in the operation theater. So that's something that we had to get used to. And in the initial days, the impatience while waiting for the burning to happen was a little bit of a challenge. But as we grew, as we grew into loving the QS, we realized that okay, sometimes we can just take a breather. Now, the new rocket on the block was the Velis, which we took on a few months ago. Again, time. Obviously, anything new is first thing is going to be the time. Once again, back to the drawing board. We got time neutral with the Mako, then with the QS, now again with the Velis. First 15 cases are 90 minutes. It didn't take as long as our learning curve for the first two robots because we have some idea. With the next 15 to 20 cases around an hour, and after 20 cases around 45 minutes of average time. Next is the feel. It's a different feel of the saw as compared. This is also a saw-based robot, but it's a completely different feel as compared to the Mako. Now, initial days we had to relearn how to use the Mako saw, going back and forth, and it has a very rigid saw. Again, the Velis saw is a completely different feel altogether. Here it's also connected to the robotic arm, but there's no haptic boundary. That's one of the major differences. It feels more similar to a conventional saw system. So initial days, I was looking at the screen and trying to, do like a Mako. Then I realized, no, I have to remember my conventional saw. It feels more like the conventional saw. Again, here also, you're not supposed to put increased pressure on the saw. But yeah, but these are the differences with the Velis saw. So we can see it auto aligns like this and does not have its own haptic boundary here. And the most important thing is you're looking in the field. Unlike the Mako, we have to look on the screen, but here you have to look into the field. So that brings us to the trust in the Velis. It's an imageless robot. So initially we were wary of the accuracy because we kept on talking about the accuracy of the image-based robot when we had the Mako and the QS. And suddenly we're using an imageless robot. But over time, we got confident in our own accuracy of data input, which is the most important factor. Everyone says garbage in, garbage out, but we have figured out our own techniques to make sure that we are very accurate when we input our own data. Finally, coming to safety, no haptic boundaries, as I mentioned. So we had to unlearn the Mako technique again, had to relearn looking into the field while using the robotic arm. So now we're looking down again. So each robot, we have our own nuances and we had our own challenges. And most importantly, the last slide, the last challenge that we faced was philosophy all over again. So once we've learned about functional alignment, now we shifted from functional alignment with a mechanical start point to functional alignment to the kinematic start point. I'm not going to go into the depth of this. This is like a whole Pandora's box. But again, this is starting from scratch. I think people have seen 12th Fail, that movie. There's that restart was the caption, right? So we had to restart all over again. But we feel that this is the sweet spot using functional alignment with a kinematic start point with robotic assistance is probably the best way to go forward. So coming back to the question that Anup sir asked me to answer, was it a cakewalk? I would say it's more like a moonwalk. There are a lot of nuances, a lot of technical difficulties. It's not easy to master, but when you do master it, it looks absolutely stunning. So I think it's not a cakewalk, it's a moonwalk. You need to take your time. You need to face all the challenges. But when you do it, you'll have the best option. I'd like to thank my team and my boss, Gurvarity, who gave us the opportunity to do all these crazy stuff with these toys in our OT and the rest of my orthobotics team. Thank you so much from Sunshine Bone and Joint Institute. Thank you.
Thank you. This is really quite wholesome to know about the challenges that we have in different robotic systems, but that's very true. So thank you for sharing your experience. So now here we are that we've decided that we need to use a robot. We have bought one. We have burnt our fingers a little in the first few cases, but now we want to adapt to workflows, forming your own algorithms, how to manage your balances. And none other than Dr. Mahesh Kulkarni, sir. He's a leading arthroplasty surgeon from Dinanath Mangeshkar Hospital in Pune. So he will be speaking on pre-resection workflows. All over to you, sir.
Yeah, thanks, Anup, and the Bombay Orthopedic Society for inviting me on this platform. Thank you very much. So what we're going to do is quickly, not all the audience to be Mako users. So what I'm going to do is quickly show a video of what we do in a standard Mako practice. So I hope you can See, can you see the video, Anu?
Can you click again on the desktop? It's click again on the share button. Yeah, that's right. We can see it now.
You can see it.
We can see it, sir.
You can see it. Yeah, that's fine. So basically, in a Mako system, which is a CT-based system, you collect several points from a CT scan, which is already uploaded in this. And then you verify that with a few points that you choose, both on the femur and the tibia. And you have this screen where this is called as implant planning screen. And basically, you choose what referencing. I hope you see the arrow. You see posterior referencing here. We have the size of the femur and the tibia and the poly that we're going to use before even we started the surgery. And then this screen seems to be a little bit cluttered. To have a look at the left pass or the coronal sections, the central noise.
So your video is breaking, sir.
So your voice is cracking, sir. So I think his network is a little unstable. Just give us a minute. So in the meanwhile, can we have the next speaker on? And then Dr. Mahesh Kulkarni can join. So what if our robot breaks down in between? What are the bailout options? Let's have Dr. Shiv Kumar Santpure sir speaking on the same. So can you share your screen?
Yes. Good evening, Anup sir. Good evening, all of you.
Good evening, sir. Yeah.
Is my screen visible?
So click once again, sir. Click once again on the share button. It will show up. Yeah, we can see it now.
Is it seen?
Yes, sir. Yes, sir.
So thank you once again and good evening to all of you. Now we know after listening to the extensive talks by all of you, now we know what is the best robot, how to use it, and what is the journey of using a robot, and what is the transition from conventional surgery to a robotic surgery. But then we face breakdowns. So the message is don't lose your heart, and we need to find out the bailout solutions. For a successful robot-assisted surgery, every step should be executed harmoniously. However, when we encounter serious obstacles during surgery, it's sometimes better to abort the procedure in a timely manner. Steps for a successful robot-assisted orthoplasty include preoperative planning, calibration of the robot, surgical exposure, fixing a bone to the robot, registration, and milling, and finally, implantation. To perform successful surgery, all these stages should be completed effectively. Even when the surgery is well planned, we sometimes encounter unexpected obstacles during the surgery. However, because we are operating a robot on a human body, a better answer may be to abort the robotic procedure and complete the surgery at the appropriate time rather than spending a lot of time on problem solving. For this reason, we should have clear information on the cause and patterns of aborted robot-assisted orthoplasty is important for effective decision making and successful surgeries in future. So coming to the type of intraoperative errors, we can classify these errors into four. One is mechanical, so any error involving the robot or the computer or the camera system. Surgeon-related errors can be caused by any member of the surgical team. Your OT assistant can be a new to the system, and errors. There can be inadvertent errors by any member of the surgical team. There can be patient-related issues such as limited range of motion that hindered normal procedures. Very stiff hip, you may not be able to register the center of rotation of the hip joint. Coming to the interactive factor, any other causes that occur during surgical steps involved in preparing and fixing the robot or registering the bones to it. So what are the complications that cause sudden shift from robotic to conventional TKR? Loosening of the femoral pin, loosening of the tibial pin, camera failure, failure to calculate the joint space, repetitive failure in registration, failure to recognize the tracker position, interruption or damage to the patellar tendon, damaged CD-ROM, where this is when you are using a CT-based navigation. The CT scan, which is stored on the CD, so there could be a damaged CD-ROM, failed sterile calibration, error in defining surface model generation, corrupted file in the robot control cabinet, and error in the handling of the pendant. So what next? Surgeons who have little experience in robot-assisted orthoplasty often have concern about the procedure. Among these concerns, damage to soft tissue and unexpected heart during the surgery may be the two worst case scenario. Moreover, the surgeon must complete the surgery manually from the point at which the procedure was interrupted, which can be another new and unplanned challenge. Regardless of regardless of what robot system has been used, the reported rates of aborting robot-assisted orthoplasty are 1% to 12%. In most of the cases of registration failure, the deformities were so severe that the primary designated points for surface registration did not exist. Severely deformed patient population might result in higher than expected abortion rate. So what is bail out in these situations? So first, you can overrule the robot, and there may be incidents where you may not agree with the robotic component size. Robot may suggest you a bigger or a smaller component. In case of severe deformity, robot may change the base of the bony defect and may suggest you to take a very thick bony cut, especially the distal femur and the proximal tibia, which you may not agree, and you can downsize the cut, you can downsize or oversize the component size, or undersizing or posteriorly placed femur may lead to anterior notching of the distal femur. So here again, you can overrule the robot, and you can oversize the femoral component, or you can anteriorize the femoral component. There are situations where you can use your conventional knowledge and skills to overrule the robot before planning to abort the use of robot. And with this minor corrections and rectifications, you can finish the remaining part of surgery using the robot as planned. Stage at which the abortion occurred is related to choice of method used to complete the surgery. When a problem occurs before surgical exposure, the surgery can be completed using any preferred method, conventional or robotic. But in contrast, when we abort the surgery during or after femur preparation in total knee replacement, procedure should be salvaged using manual technique from that point on. Thus, for a robotic assisted orthoplasty, the surgeon experience and knowledge of entire surgical procedure, including the conventional technique, are critical. Moreover, in case of unexpected abortion, instruments for the manual operation should be prepared. Classification of the causes of aborted surgery by type of error may help in prevention in future. Purely mechanical, surgeon or patient factors were relatively simple to manage. In cases involving a damaged CD drive could have been managed by preparing a backup CD. In this discussion, we wanted to introduce possible errors and obstacles that can occur during the initial phase of robot-assisted orthoplasty. With this, we believe that we can help surgeons to prepare, handle, and even avoid the problems. Now we consider the robot a good assistant to guide the way in our surgery. Undoubtedly, the best scenario is uninterrupted and precise surgery. However, because we can complete the surgery successfully from any stopping point, we think that sometimes it's better to choose to abort the robot-assisted procedure than to incur increased risk when we meet serious problems during surgery. This flexible approach and comprehensive understanding of causes of errors markedly reduce the surgical time, dissection, and interestingly, the rate of aborted surgery itself. So take-home message is prepare a backup CD for use in every case. If time allows, repeat the step or replace the malfunctioning part. If the patient is under anesthesia for a long time, abort the robot-assisted surgery procedure. Compared with conventional manual-driven orthoplasty, robot-assisted orthoplasty in its current version has some limitations. It requires wider surgical dissection, longer duration of surgery, and additional complex procedures. Sometimes you have to overrule robot with your conventional wisdom and continue with the robotic surgery till the end if possible, otherwise shift to conventional surgery. So before preparing this talk, I looked into the literature. So there was hardly any literature on this topic. So these were a few references I could gather. Thank you, Team WIROC, Team BOS for allowing me to participate in this webinar, and all the best for the prestigious WIROC conference this year. Thank you so much.
Thank you so much, sir. And that's very true. There's not much literature on bailout options. And that's when the real skill of the surgeon comes out, in spite of using robotic surgeries. So I think many glitches can happen. It's important to identify them and rectify them at the right step. I think that's the take-home message. Thank you, Dr. Santpure, sir.
Yes.
Can we have Dr. Mahesh Kulkarni, sir, presenting his talk?
Yeah. Sorry, Anup, I think the network was pretty poor. So I have
Right, sir.
reconnected again. Let me see if I can share the screen again.
Yes, sir, we can see
And
it
hopefully
now.
you can see it better this time.
Yes, sir, yes.
So
Better.
thank you very much, WIROC and the organizing team, for the invitation. I hope you can hear me now.
Sir. Yes, sir, you're audible.
Can you hear me?
Quite clearly now, sir.
So basically, the CT scan information already has been fed into the computer. And with the MECO, I'm talking about MECO because the topic for me is pre-resection balance and mid-resection balance. And I want to quickly explain what that means. So basically, with the CT scan, you get this planning screen where you allow yourself to choose what referencing way you're going to use, posterior or anterior. You choose the size of the implant, the size of the poly as well. You can use anterior referencing if you are familiar with it. You can use a PS knee or a cruciate sacrificing insert, or you can use a cruciate retaining knee design according to what you feel. And basically, then intraoperatively, after the surgical approach, you collect certain points from your screen. I will just explain it in a minute. In the preoperative section itself, the green is the implant and the pink line is the bone on this. You match the trochlea, depending on what size it is. You match the tibial platform. And in the sagittal screen, you match the posterior condylar offset. So you can actually perfectly recreate the patient's anatomy using the preoperatively based CT scan. Once you've done that, you go to the surgical approach. You have planned your implant. You go through your surgical approach, collect points intraoperatively, as you can see here. And then you can verify that with what the robot has got from the CT scan. Once you've done that, we the ligaments in flexion and in extension, and you see what are the gaps that are going to be. You remove all the osteophytes at this stage. You check the flexion gaps, and then you check the extension gaps. And that can be done either with pair of osteotomes or a pair of spoons, which is provided by the company itself. So here we've checked the gaps. And the next thing we do is you balance the knee replacement, what is called as a pre-resection balancing. So here my gaps, which were calculated, were on the lateral side, 21 in extension and 20 in flexion. And on the medial side in extension, it is pretty decent, 16, and in flexion is 13. We're hoping to get the gaps to approximately 18 or 20 in all the screens. And here you can do what is called as balancing of the implant preoperatively, and you can start moving the femur in the sagittal as well as the transverse plane, making sure that it matches the patient's anatomy. Here you can see that the gaps now are put, we've reduced the lateral gaps to 18. So that is the first thing we used to do. And then try and put some virus into the tibia. I put 1 virus, which allowed me to get the balancing well. And this is called as pre-resection balance. If I know that I've got the medial gaps to about 15, 16, and the lateral gaps are stable at 18, here we are trying to check that the implant is not going to notch, the posterior offset is going to match. Everything is done before the planning itself. And this is called as pre-resection plan, and you can just start cutting. It can be so reliable, as Adarsh has already mentioned. In a few cases time, you will allow your assistant to do the balancing itself. And once the resections, the haptic feedback we talked about the saw blade cutting exactly what you want, and then you trial the femur, and you can do limited soft tissue releases. So that is the standard pre-resection balancing. Now I want to give you some idea of what pre-resection and mid-resection balancing is. So let's now see, this is the pre-resection workflow where you do the initial assessment, you check the gaps, you adjust the implants, you balance the gaps, you complete your bone prep, and you directly go to trial. And this is what is called as a pre-resection workflow. Whereas what we do in a mid-resection workflow is here you can see the differences. So initial assessment, you check the flexion and extension gap, you balance the implant, you adjust the implants, you can put in, depending on your philosophy, whether you are a follower of mechanical alignment, functional alignment, or kinematic alignment, you can put the implant in those boundaries that you have defined yourself for, and then see how much is the gap balancing that is needed. That can be done with releases. and then you can directly move on to bone prep. Whereas in a mid-resection technique, what you can do is, if you want to do a conventional kind of surgery, you can get the initial plan adjustment. If you're not able to quantify, if there is a huge posterior osteophyte on the femur or a huge posteromedial osteophyte on the posteromedial tibia, what you can do is you can just do a proximal tibia resection, which can be a limited resection. So instead of taking out 7 millimeter from the lateral tibial plateau in a varus knee, you can take 5 millimeter from the tibia, and then you can do the tensioning again. Especially useful if the patient has got, say, fixed flexion deformity, or if you cannot quantify the releases achieved by the posterior osteophyte removal, you can do a limited proximal tibia resection. You can shift the implant on the planning screen distally, so you reduce but cut the distal femur. You can shift the implant posteriorly and cut the posterior femur, which will allow you to get access to the posterior osteophytes. Remove the posterior osteophytes on the femur, remove the posteromedial osteophyte on the tibia, and then you again tension it to see what are the final adjustments. So this is called as mid-resection balancing. So I think that is all that we wanted to talk about. So if there are any questions, we can take them. So the differences between pre-resection balance is in a smaller deformities, you can adjust, take your ligament tension, you can adjust your component position, you can achieve the final balance on the computer itself, finish your cuts, trial your implants, and do limited releases at the end. In a mid-resection balance, like we do in a conventional knee replacement, you can do limited proximal tibial resection, limited distal femoral and posterior femoral resection, which will allow you to get access to the posteromedial osteophyte on the tibia and on the femur. You can remove them, reassess the gaps, and make the final adjustment in the implant to get you the perfect balance without much of soft tissue releases. And I think a CT-based robot helps you into that, because it will allow you to see the posterior osteophyte. When you size the tibia, it will allow you to see how much of reduction osteotomy you are going to use. So by all of this, the mid-resection workflow will not allow you to have bigger gaps than what you can expect. So I think these are the main differences. And I'm restricting myself to one system, image-based system, which is the Mako system by Stryker, which allows you to do all of these workflows as well. I'm not aware whether that, probably think the other systems allow it as well, but the autonomous system will just go on to burr everything. You can stop it at some stages, but it is difficult to change the plan after that. Okay, Anup. So
Yes.
you can have any questions or any doubts that we can discuss quickly.
Yeah, so I think that's pretty useful, as we have seen Mako or image-based systems versus imageless systems. And I think it's important that we have a mate of conventional as well as robotics. So understanding of conventional is absolutely important when we are dealing with difficult cases. And that's what Dr. Kulkarni sir is saying, that it's not a difficult or a different strategy. We need to have and use robotics to our advantage when we are dealing with difficult cases. So thank you, sir, for the perspective. I think once people embark onto the journey, they will be more confident of how to change their workflows based on the case that they are seeing. Impromptu, sir. So thank you, sir, for a wonderful talk.
Yep.
Yeah, so now we have decided to get one robot. We have seen what the first few cases are. We have seen what are the bailout options. Now, can I expand my usage of robotics to all kinds of cases? And let's see whether they have a universal, versatile appeal. So for that, let me invite Dr. Vaibhav Bagaria. He's the Director of Orthopedics at Sir H.N. Reliance Hospital. Sir, all over to you.
Anup, can you hear me?
Yeah, we can hear you, and we are seeing your presentation too.
Okay, thank you so much. Thanks, Anup, for inviting me to this interesting session on robotics. My job is to talk about how difficult cases can be made easy with robotics. And we had very interesting lectures preceding my talk. And one thing that I would like to tell is, that others talked about being time neutral. I think the way you become time neutral with robot is by doing difficult cases. For if someone says that for their easy cases, the robot takes time off, I don't think that's the truth. It does take 2 to 3 minutes at least extra for every primary case to be set up. But for difficult cases, it definitely saves up to half an hour to 40 minutes. And you'll see all these cases that I'll be showing. I'm just showing 3 cases in which we could do it under an hour, which normally would have taken us more than an hour. So I'll begin with 3 simple cases. One is valgus, one is extra-articular deformities, and the third is a revision scenario where we use the robots. So let's begin with this valgus knee. So you can see this is sort of a windswept deformity. On the right side is a valgus deformity. I know it's not like an extremely difficult case, but the reason I put this case here is to understand that this is the heart of the operation. Okay, so this planning screen, irrespective of which robot you use, Mako, Cori, Velis, is the heart of operation. And why I call this as the heart of the robotic operation is because it is completely flipped over on the way we looked at the alignment philosophies. I think with whichever philosophy you use, I think the balance has taken precedence over the alignment, provided that you are not deviating too far away from it. So this is a scene that we get once we had this case. We'll see that the robot always chooses a resection level of 9 millimeter on the lateral side. And so this is the gaps that you collect without stressing. So in this case, we'll see that there's a valgus knee, and that is why you can see that the medial side is opening up and the lateral side is tighter. Now, again, when you stress it, the medial and lateral gap in flexion seems to open up, but on extension, the medial side is much more opening up than the lateral side. So for understanding of people who do not understand or who are new to the robotic, these are different colors for different things. In this particular system that I use, which is Cori, the orange graphs represent the medial gap opening and the violet graph represent the lateral gap opening. Different system will have different colors, but this is the crux. You have to know what the gaps are, medially and laterally. Once you know, and it has to be stressed and unstressed. So this one is in stress. So this was the vara stress, this is the valgus stress. So you take it in 2 stress and you see how the knee behaves. The experienced surgeon will assess it manually, but the key of robotic is to understand that you can do it objectively. And this is what this graph has shown. So take a minute of pause and you can see that as you expect in a valgus knee, the medial gaps are larger. The lateral gaps are relatively smaller when in extension. And again, different system will have different screen, but this is how, if the robot had planned, this would the gap, this is how the way the gaps will look. And this is basically flawed because the robot is taking a 9 millimeter lateral cut for a valgus knee, which is wrong. So, but it takes it by default. So this will show that if you took the gaps as proposed by robot, this is the end gap that you will get after you have put the implant. But we all know that this is not what we want. We do not want the gaps to be this high. So what we do is, you see, I have reduced from 9 millimeter on lateral side to 2.5, and instantly you will see that it looks much more reasonable. You will see that there is tightness on the lateral side in extension. With this amount of cut, the medial side is more or less balanced and the flexion is slightly loose. Now, normally this is very difficult to comprehend because if there is some tight structure on the lateral side, it should be tight in both flexion and extension. And that's why the robots are important, because it tells you not only the gaps of medial and lateral side, but a different varying angle of flexion and extension. And I think that's one key point you should understand, that the benefit of robot is not in execution. Just, I mean, of course, execution has its own role, but understanding the gaps at different angles and how to manipulate your cuts to minimize the releases. So once I reach this, this looks much more sane. So what we do is, we do some more tweaks by dialing in rotation, by dialing in valgus, and achieve this gap. So always when you're doing a robotic, look at the normal side and try to recreate the normal anatomy of the gaps. For example, if it's a valgus knee, always aim to recreate the normal anatomy on the medial side. Similarly, if it's a varus knee, your lateral side is usually good. So you should recreate or get 0-0 in at least two of the blocks, which is the lateral in case of varus knee and medial in case of valgus knee, to start with. Because once you do that, then you are being physiological. And once you are being physiological, what you need to manage later is either by your cuts, the pathology, or by release. So robotic is a 3-stage procedure. One is basic release, the second is juggling with the cuts, and third is fine-tuning your release. And doing it objectively is what robots help. So in this case, you see, I have chosen this to keep the extension still tight and do again a little bit of adjustment here by dialing in 1 degree of varus to get the flexion absolutely correct. So flexion medially and laterally is balanced, and the only thing that remains is tightness in extension. And now we have known that for every millimeter of cut that you take, there is an automatic release of around 2 millimeters. So if on the tighter side, not on the normal side, but the tighter side. So with a 2 millimeter of cut, if there was a tightness of around 3 to 4 millimeter, that would automatically get released because you are cutting the bone. So with this planning screen, I move on and execute my cuts here. And again, I'm doing little tweaks and I'll do it differently at different time. This is the execution. And you'll see the second advantage of the robot is that the accuracy. So I've got sub-millimeter and sub-degree accuracy on both my cuts and on the tibial cut as well. So this is the level of accuracy that a robotic system gives. And once you reach that, you will go and you'll find that your gaps are almost symmetrical. It is at the baseline at what you want. In varus knee, I expect 1 millimeter, but for valgus knee, I expect almost flat line. And that is what it is. And if you see at the post-op X-ray of both right and left side, you will not know which is varus, which is valgus. You'll see the alignment which is there. And indeed, you will see 0-0 degree on scanogram. And mind it, it is all with a 9 poly and in 45 minutes of time and with no releases. So this is a basic valgus. Now we move on to more complex deformities. For example, this one. And all of you will agree that this is not a very simple deformity. You've got such high degrees of valgus, you've got implant inside, and most people will start thinking in terms of stage surgeries. Of course, the anatomical landmarks are altered. The IM rod is very difficult. Ligament balancing may be compromised. There are scars and previous implant. We chase a high survivorship and a good forgotten joint score. Now, again, the decisions are multifold. We'll have to look on whether we have to do 2 surgery, 1 surgery, 2 side, 1 surgery, 1 incision, 2 side, or 1 surgery, 1 incision, and 1 side. So now when we look at this case, we decided to use 1 surgery, 1 incision. And when we started, this was the gaps. You will see this is the right side we are talking about. So you'll see that the range is very restricted despite the primary releases. So it's a stiff knee. It's got tightness on the medial side and slightly on the lateral side when it is unstressed. And this is how the curve looks. So if you look, there is a recurvatum deformity, and this is how the balancing looks without doing anything. Now, if you look at the whole screen, I think the video did not play here, but you would have seen that I have juggled with my cuts by maintaining the non-negotiable criteria of dialing in certain degree of varus. And this is how it looks. I removed the implant because it was coming in a way, but this is how it looked. And again, with a 9 poly. Similarly, on the other side, which is a 31 degree valgus, if you look here, we had these gaps, which was again a very paradoxical thing because the flexion space was quite tight compared to the extension space. And if you look at the final thing, again, for some reason, the video is not playing here of the balancing. Otherwise, I would have loved to show. So this is how it looks like on the post-op. So it's a 5 degree and 0 degree here. And here we have not removed any implant. And again, using both sides, only a 9 millimeter poly. So key technical plan is you pre-plan the amount of deformity, focus on the balance. And the balance in flexion is also a surrogate guide to your femoral rotation in flexion. Now we'll be also showing, in the next case, I'll show how to use special point when using robotics. Of course, we have a low threshold for using stem extender and low threshold for minimum constraint when in doubt about the collaterals. Now let's look at how we use the robotic in a revision scenario. Now we know the goal in revision arthroplasty is simple. It is the restoration of proper limb alignment, achievement of proper prosthetic component position, restoration of knee biomechanics, and a balanced gap both in flexion, extension, and medial and lateral. We use the standard pathway, which is preoperative planning, exposure, component removal, assessing the bone defect, tibial preparation, femoral preparation, gap balancing, and bone defect management. So this was the standard thing. But I'll show you, this is a case of a failed uni on the left side. And what we did was, I hope the video runs now. So we have first mapped the whole thing with the implant in situ. We have not removed the implant. And this red thing that you are seeing at this special point, I'm marking where the component was. And again, I'm using my manual override to know how the white side line is, because your posterior condyle may not be as accurate as you had thought. Then you, of course, go and plan your tibia, again with the implant C2. And as I said, the key is the gaps. And if you do it with implant, you know how the native collaterals are before removing the implants. This is how I have mapped it. Again, I am using the special point to mark out where my implants are. So this is how it looks on the screen. And you will see that once I know that, I am chasing this gap to see how the gaps were. So yeah, so this is how the gaps look like at this stage. And you'll see that this is the screen. Again, because there is a component inside, it's showing quite amount of tightness here on the medial side. Now with the whole balancing thing, now once I've done this, so now you'll see that I am altering all the parameters here to kind of get my cut that I wanted. And once I have done that, I will blur it off, and all the red area that you are showing is the bone defect. So obviously on the medial side, after removing the implant, there are much more red areas. So I know where to put my augments or a graft if I need to. Again, once that's done, I'll do the same thing on the tibial side. And once that's done, you will see that you'll see above that the tibial side is showing a large amount of defect here. Okay, so this gives me an idea of how the bone is. On the lateral side, I've got what I wanted to achieve my desired gaps, but on the medial side, I know that there is defect which is much more than what would be just covered by a tibial plate or with a bone graft. So I've decided that I'll use a wedge cut here, and this is the amount of the wedge cut that's required. So you can actually put your validation tool to see how deep it is. So once that's done, and also if you see that red mark there, that's again an important point, because I'm running my burr without any control. Because if there is a sclerotic bone, you just want to rub off all the sclerotic bone, and that is what that red mark shows. And once that's done, you'll see that it's achieving a 2 to 3 degree of varus and a good range of movement. And same thing with the balance. Again, you'll see that it was only done with a 9mm poly thickness. So if you look at this X-ray, a revision X-ray with minimal wedge, a 9mm poly with a CR implant. And all this was possible because you had robotics and you had confidence in getting your gaps correct. So that's the advantage. You can use much more bone preserving surgery. So at least a CR implant with only a 5mm wedge and a 9mm poly, despite being at a revision situation, and the whole surgery takes less than an hour. So the amount of information that you get out of the robotic system is immense. I know it's sort of a mix of basic and advanced audience. So I tried to keep it both ways, where I could balance the basics as well as this. So it may not have come out as clearly as I wanted, but I hope you get the gist that today the kick that I get out of robotic is not by just the simple cases, but by doing these complex cases. And the real benefit of robotic is indeed when you are able to do these complex cases with least bone destruction and saving time. Thanks once again, Anup, for giving this interesting topic to me in such a short time. It's sometimes difficult.
Thank you so much.
Surgery. It's easier to do surgery
you did really well.
Than to explain it in such a short time.
No, you did really well, sir. So I think that's very true. So I think with the robotics, the whole idea is to take away the uncertainties and look into the future. What if we know that the future is predictable? And that's what robotics are helping us to do by attention data. We know where our implants would be and what the gaps would be. I think that is something that has put surgeons at ease, especially when you are doing robotics for difficult cases as well. I thank you, sir. It was quite a good talk. And now we go on to Dr. Raja Bhaskara. So he's from Ganga Hospital, Coimbatore, and as we all is one of the high volume centers in South India, and they a lot of robotic cases happening, but are they sufficient to satiate the needs of a high volume center? So can we scale up robotics to that kind of a situation in a hospital? All over to you, Raja.
Yes. Thanks a lot, Anup, and thanks a lot to Bombay Orthopedic Society. And am I audible?
Yes.
Yes. So at the, I know
Yes,
it's
yes.
really so nice that, I've been given this opportunity to talk with most of my seniors and also my very good friends here. And me being the last speaker in this session, I'll try to convey the point when Anup told me about, scaling up. Is it possible or can it be matched in high volume centers? What has been our experience with this? Now, this is actually a very important slide, and one slide which all of us, the entire webinar, we started from, whether robotics was necessary or robotics was not needed, and then we got convinced it was needed, which is the best robo. This one slide, in 1998, there was this chess championship between Deep Blue and Gary Kasparov, and Gary Kasparov lost 2-1. And that was a time when, the Time magazine in New York, it came up with computer defeats man. And that was the first indication of how, this robotics, AI generation, they were going to have a very, very big say. And from the time when, people started disapproving, now people have realized that, AI and robotics, it was a watershed moment in history for us to realize that AI, robotics are a part of our life. So I think there is no question that, whether robotics is needed or not needed. Now, why should we scale up? This is a very good book for anyone if you want to read. What got you here won't get you there. It's very important. And in this book, they clearly explain about, if you have been a very successful player in any aspect of what you are doing, that is not going to sustain for a long time. You need to reinvent yourself. Now, are we ready to scale up? Are we ready to scale up? And if you see in these entire 4 different aspects, so what are the aspects of scaling up? It is people, strategy, execution, and the cash flow. So each business, each modality has different ways how they scale up. But this is the point which I highlight, you need to execute the 3 key habits to have a successful, whether the same processes are running smoothly and above all giving superior profitability. So if you are a high volume center, the last thing you want is, and you are a high volume center, what has brought you there is your proper work, your clinical efficiency, and the good results you are giving. You don't want to scale up with you having a compromise of the running smoothly. You don't want to have less number of cases, more complications, and above all, having a poor profit margin. So this is a very important aspect which you have to take, whether you have to scale up. So let us take our institution, Ganga Hospital, 2023. These were our statistics. 650 beds, including orthopedics and plastic surgery. So 23,491 surgeries were done overall, with about 14,000 being exclusively orthopedics. There were a lot of the open injuries which involve plastic and things. So they also are involved in that. So this was our statistics. 3,296 total knee arthroplasty cases were done in 2023. 275 cases of joint replacements in the knees, approximately around a month. 5 specific surgeons and 7 fellows working with us. So on a month, when you have to do about 275, we're about 65 to 70 joint replacements every week. How do you scale up to that level? Is it worth scaling up? What were the things which you have to take into consideration? So our robotic journey was, we didn't go ahead with the initial in 2019 2020 when the robo came. I'll explain to us why. But because we were actually using the DEPU system, so and when we knew the DEPU system, we did not want to change our entire practice, what our theater team, what we have been skilled in, what we have been practicing for the sake of robotics. So in May 2022, when India's first Wellies Robo, we launched it, and there were subsequently many launches happening, and now I understand there are about 43 machines. So the questions which we had when scaling up were, how do we train our team? If you have to train our team, is it only the surgeons, but most importantly, the theater staff, the OT staff, the entire people in the OPD? And these were the factors which we had to take up when we had to do our training personnel. Now, the points to be considered before we went to robotic, the time taken for a surgery, conventional was approximately around simple knees for about 35 minutes, not including the closure time. Now, if we are going to include robotics, the cost is going to be 20% more. And counseling of the patient, the benefits, how much are you going to counsel the patient? Because frankly, in the robotic surgery in medicine, the amount of benefits it's got in some like urological surgery or gastrointestinal surgery, in orthopedics, it has not been a game changer when you compare it with conventional surgery. And that is the point which I want to come in. How much will the robo be exactly beneficial to our patients? Now, this is a very interesting and very important curve, which you see whenever you have to go, and especially with whether you're a high volume center or even a normal practicing surgeon, whenever a new technology, in this case, robotics comes in, there are these tech enthusiasts who are the innovators and the early adopters, someone like Elon Musk, who go and they are a really different mindset. They form a very few percentage of the tech enthusiasts. The majority of the people are in the center, but there are these laggards, the 16% who do not come into the picture at all. But the pragmatists and the conservatives are the early majority and the late majority people, and they form most of the thing. So we have to take the call whenever we are scaling up. Where are we in the curve exactly? Compared to your district, your state, your specialty, you need to first of all work up and find out where you are. And most importantly, you need to decide, do we even want to be in the curve? So let us take this case with Wellies. We use the imageless Wellies robotic system. We use only one system. And this is actually a post-traumatic extra-articular deformity. Now, if you know, this was all planned. And for such a case, there is no question at all, in spite, if you have to draw the angles and that do the 2-stage, 2 incisions, 2 surgeries. But intraoperatively, when you calculate, one of the advantages of the Wellies is you get this accubalance. Now, accubalance exactly tells you during the various ranges of motion, what is the tightness, what is the stiffness, how much cuts you need to make, where will you get after cut, and you can also adjust your rotations everywhere. I'm not going into the technicalities of it. And post-operatively, we have this. This was all done in the robotic system. Now, this was actually took 54 minutes. The cost of this entire surgery for the conventional compared to the conventional one was 15% more. Now, is it worth it? 100% in such a complex case when you know robotic is completely worth it, the time, the effort. Now, coming back to this curve on scaling up, I think as a high volume center, the only question you have to be is, you have to definitely be using the robo and you have to be on top of the curve. You don't need to be an early adopter. You need to be on the top of the curve, and you need to find out how methods are going to be made, where you can scale, how you can train your team, how you will be able to deliver the best when you adopt this new technology. And so going back to this book, what got you here won't get you there. You have to modify that. What got you here alone won't get you there. You do not need to change your practice. You do not need to completely change your religion or anything in this spot. You just have to modify it, accept it, and then work much for it. So why are you scaling up, especially with robotic surgery? There are different aspects why you need to do. Is it for a business model? All the many hospitals in our city or many hospitals in our state are getting the robo. Should I also get the robo for a marketing purpose? Second one is, will getting the robo increase my financial model? after getting the robo, when will I be able to break even with the investments made? Those are two different aspects of how you look into it. But the most important thing is, the patient safety and patient satisfaction. These are two important things as surgeons we have to be focused on. And the last one is staying relevant, staying relevant in the market. If you don't adopt technology now, will you even be able to adopt technology like how Kodak, Nokia, they all fell out of market? Now, this is a very important slide. Technology should be your servant, not your master. Now, if you read this in proper perspective, and if you go much deeper into understanding, I think you always have to treat the robo as your servant and not as your master. So treat the robo as your servant, not as your master. So if we ingrain this, then even in a high volume center, actually, it gives us more clarity that, you have to only use it for complex cases and only for cases when the patient asks for it. Every single case, you don't need to use the robo. And most importantly, you should not sell the robo to the patient. That's one thing which we practice. And after getting the robo, we do not need to get overburdened and all these are possible because it's in a high volume center, and because you have scaled up, you are able to manage even on the financial aspect and also on delivering the same quality for your entire team. Now, this is the paper following our first 200 knees, comparing the wellies and the conventional things. So this was actually done by a third person, like one of the visiting fellows. He calculated every single score. And if you look, 100 knees on each side, radiologically, we calculated the MPTA, the LDFA, and also the alignment. The robotic TKRs had better parameters, which were significant. But functionally, at the end of 3 months and at the end of 6 months, both the robotic TKRs and the conventional TKRs did well. So you have to, even after buying a robo, you have to be convinced that conventional TKRs also do well. And you don't need to completely jump, and you don't need to sell the robo. You don't need to be a servant to the robo. You need to be a master. You need to decide for which cases you need to know. And that will help you manage your time, your efficiency, and also give good outcomes, and also attract the people on the pay scale for you to get a good outcome when you are planning with scaling up. So our experience, I think scaling up in high volume centers, definitely it matches. Definitely it's needed. It needs adequate planning. You need to get your entire team tuned to it. All of them need to get trained, your status staff, your technicians. You need to plan your timings. You need to plan initially, as the previous speaker said, there will be some time delay, but then things become financially and surgically. I think high volume centers, definitely it is viable. And if at all, wherever it is viable, I think it's only the high volume surgeons, the centers which can make it viable. You need to train more individuals, but always remember you have to scale up considering the patient safety and the benefits, not for the financial aspects. And most importantly, surgeon and the operating surgeon is always the master. The robo is not. So this was a statistics which we took like October 2024, 367 total knee replacements were done in our institution. About 1/3 were only robotic TKRs. And the average time for a robotic TKR now, since we got a little bit trained, it's about 43 minutes. This is not till the tourniquet is released, so till 43 minutes. So I think this is the model which we follow, that even now, when we go back, around 25 to 30% of the knees which are done in our hospital are robotic knees. And still, we also fall back, and we are still convinced that conventional knees also do well. And that helps us, also keep up with the numbers and also deliver to patients, especially related to time, efficiency. And as you see, this has been our journey with scaling up with the robo. I thank you for your attention.
Thank you, Dr. Raja. Wonderful talk. So that is really the experience of high volume centers in Coimbatore as well as Sunshine in Hyderabad. So I thank you for all your knowledge sharing. It really means a lot to us as Team WIROC, having pan-India speakers delivering their experience. And I hope to see you all during the proceedings of the conference. So are there any questions that we would have to ask on the panel amongst ourselves? We may have a minute or so.
All okay.
Yeah, good. So I
Yeah.
think we are through with the time
Wonderful.
for the day. And I thank you for investing your precious time out of your practice, out of your family time. And I really appreciate that. And I hope it all adds out to collective consciousness of surgeons of this generation to use robotics prudently. And I am sure we have a bright future ahead. I thank you all for your time. Thank you so
Thank you,
much.
Dr. Anup. Thank
Thank
you.
you. Thank you, Anup. Thanks a lot.
And
Bye.
see you. See you all. Thank you.
Thank you.
Thank you.
Sandeep, you there? Sandeep, you there?